Excellent job, all speakers. We do have about 15 minutes for Q&A. So if you could raise your hands. Anyone have questions on either side? Yeah, we have one over here on my right.
Good morning. My name is Frank Maroney. And my question is for Dr. Margolis and Terry from the hospital. I heard a lot about population management. And one of the things that perhaps I missed or was not quite clear to me was, how do we transform people from being users of the system to being consumers? And do you think that lies within your responsibility? Thank you.
I tried, obviously without great success, to talk a little bit about the demand side and the supply side, and maybe that euphemism isn't appropriate. On the demand side is to make consumers smart, intelligent users of healthcare. And that's a lot of what Chris said relative to identifying folks at risk, gaps in care, helping with self-care, some of the things that you heard at the earlier meeting about patients being engaged. And then on the supply side, it's absolutely about patient education. My view is the physician of the future is a trusted advisor to an informed consumer. And if we can get there so that that trusted advisor can help people navigate through a very complicated system, I think we will have made some major moves in that direction.
Well, I think that that would pretty much sum up what I would say. The only additional thing, we're starting with our staff, our employee population. We went self-funded this year. Actually, all of UC went self-funded, developed a self-funded alternative. It's not the exclusive plan for our staff. And in that, we have education going. So we're kind of piloting some activities around that within that scope of things. And I would just echo then what Dr. Margolis says.
Any other comment? If not, we'll look for another question. Any questions on the right side over here? No? Any other questions on the left side? Yeah, one way down in front, please. And we need the microphone for the people in the other room.
Yeah, hi, this question is for Dr. Margolis. I know capitation worked really well in the mid to late 90s. We saw a trend to premium for employers relatively flat during that period of time. And then it just hit the fan right around late 1999, 2000. Do you think the medical groups now are in better financial shape to handle this risk, or what lessons have been learned from, 15 years or so ago?
There aren't a lot of advantages in getting old, but one is that you've seen this picture before. And so you're absolutely right. And we said, and Cheryl repeated it, that a lot of people willing to take risks that aren't prepared. And so I think the movement towards consolidation, while it scares the antitrust people and the FTC folks about price setting and price gouging, and guys like Bob Berenson will talk about that all day long. On the other hand, the alternative is this unstructured, uncoordinated, disaggregated system. So I think you're going to see more capable organizations, some of them health plans supporting physician groups. That's a big part of the Optum strategy, as I understand it, or Aetna. Some of them being big physician groups or these hospital verticals that I described being much more information-centric, much more population health-centric, bringing in clinical leadership, creating strong clinical teams. Cheryl mentioned primary care shortage. I think the scope of practice, getting nurse practitioners, PAs, very much embedded in the clinical teams with a higher level of capability and accountability, I think are all moving that in the direction. Will it be totally without crashing and burning? No, I'm sure there'll be plenty of crashing and burning again.
Any other questions? I don't see any, so I will say once again, oh, we do have one. I'm sorry. We have one right here. Thank you.
Hi, my name is Tiana Riskowski, and this question's for Cheryl. I'm curious to know what, if any, effect you think there will be on hospitals now that Standard & Poor's is looking at changing its bond rating system to include much more than just financial information, but quality and strategy in the changing healthcare landscape?
Yeah, thank you for that question. So, first of all, there's a very big difference between the ability for the for-profit publicly traded hospital companies to access the capital markets and the rest of the majority of hospitals, the not-for-profit world. That started back with the credit crisis in 2008, and frankly, it hasn't resolved satisfactorily. It's gotten a little better, but it really hasn't resolved satisfactorily. So in the context of that, for the for-profit publicly traded hospitals, it will mean zero. There is so much money around in the bond market, in the lender channels, that they are chasing risky deals and pricing them as if they're treasuries, risk-free. And so as a result of that, I think you could downgrade on a credit on quality, and it will have zero impact on their ability to finance. But if you downgrade the credit on cash flow, it will have big impact, because that's really what bond guys are going to look at anyway. So it's nice of them to offer to do that. They need to get the rest of their ratings right. Now, on the not-for-profit world, I think it may be very different. There's already a lack of access to capital. It's still difficult to find funding. So anything that makes it more difficult is really bad for them. And I think what it does is it drives consolidation into the hands of those who have capital from those who do not. So you're going to see a tremendous amount of consolidation for a number of reasons, access to capital being the primary reason, this being one factor in why access to capital is an issue.
Very good question. Yeah, we have one over here on my right.
Thanks. I have a question for Dr. Skolnick as well. You used the phrase "at the Wall Street level," and it definitely seems to be that that's the level of conceptual sophistication that we need to start discussions at. Do the Wall Street folks with a vested interest in population health talk to the Wall Street folks with a vested interest in helping what I'll call the salt, sugar, fat community stuff more food down our gullets? Do they talk?
So do you mean that the healthcare analysts talk to the consumer and food analyst? And,
Yes.
and the folks from General Mills and all those other who covered,
How does
yeah,
that
no.
conversation go?
No.
Coca-Cola.
Okay, any,
So let me just, I can't even get my own organization to implement any of the things that Cigna offers us to change behavior internally. Okay, so never mind, talking about it seriously. So you've got smart people about what needs to be done in healthcare. I finally have them letting me help them to pick an insurance company. The next step is, guys, there's these really great tools that can help us manage our risk down, manage our risk down, manage our costs down. And one of the issues that and I've said this before, state law actually in Connecticut makes it very difficult to provide financial incentives. So not only don't we coordinate within the research department, not only do investors not coordinate to say we should short the food stock because it's not good for the healthcare stock, that will never happen.
Another question? Okay, please keep your seats because we do have a closing comment from Paul, but please thank Chris, Bob, Terry, and Cheryl for a great presentation.